talk now. Okay. All right. Well, so today the talk is on the lessons we can learn from the PHR in 2020, and I hope this will be useful to you. The two sources of data that I'm going to be talking about are the Paediatric Hospital Reporting Program, as I said, you know about it. And this, for last year, that includes clinical data from 24 hospitals. And those 24 hospitals is more than we've ever had before. So it's a great achievement, I think, that we were able to get comprehensive one-year data from 24 hospitals, many of which this year were rural district hospitals, and some urban hospitals. And if you want a summary of the data, you can look in the Annual Child Morbidity and Mortality Report. That's the report there, and the link to that report is at the bottom of the screen. I'll also talk a bit about the Demographic and Health Survey, not too much about that, but just so as all the people who are sitting there, DCH and Masters of Medicine, really understand how to. I'll just admit some more people as we go. I'll just break a moment while they come into the talk. So I'll just go back. These are the sources of data I'm going to be using. The Paediatric Hospital Reporting Program, which for last year we were able to gather data for an entire 12 months from 24 hospitals, and that's all summarised in the Annual Child Morbidity and Mortality Report. The link to the report is at the bottom of the screen. I'm going to be also just touching on very briefly the latest Demographic and Health Survey, just so as I know that the paediatric trainees know how to calculate under 5 infant and neonatal mortality rates, and also how that differs from a case fatality rate. So if you want more details on the report, please go to the Child Morbidity and Mortality Report for 2020. This is the 11th annual. I'll just let some people in. Sorry. This is the 11th annual Child Morbidity and Mortality Report, and I think you'll see as we go through the data that there has been some real progress in certain areas. And I hope that it illustrates to you the sort of changing nature of the epidemiology of child health. So this is the program. For those who don't know, this is the program that we use to gather the data from all the hospitals. Most of you will have seen it when you've been working in your hospitals, because it's so widely distributed now. And the same sort of data that you previously would have gathered from in your admission record book, but it enables us to calculate very accurately case fatality rates for many different diseases, and to know exactly the number of admissions and deaths, and as I said, the case fatality rates. And this, you can see that this is version 12 of this program now, and we started this program in 2007, 2008. We designed the program, and it has been modified multiple times in that last 13 years now, and I hope we've reached a stage actually where we don't have to modify it too many times, because every time we change the program, the computer program it's based on, there has to be a sort of new round of implementation and installation and training for staff. And I think we've virtually got the program really accurate now. The version 12.1, which is what we're using, is very accurate, and the data that I'll show you mostly comes from version 12.1, although some hospitals are still using version 11 and version 10 for last year, but we hope by next year we'll all be using version 12.1. Just to go back over what a definition of mortality rates are. So I want you to understand there's a difference between population-based mortality rates, and I'll just admit Annette, she's come from Vanuatu. There are population-based mortality rates, and then there are hospital-based mortality rates. And hospital-based mortality rates we often call case fatality rates, but there's someone else coming in, so I'll just admit them. But when we are calculating a population-based mortality rate, that's the number of deaths up to the age of 5 years for an under 5 mortality rate or a child mortality rate, or up to 12 months for an infant mortality rate, or 28 days for a neonatal mortality rate. And remember, a rate is a numerator over a denominator, and the denominator in child mortality rates is per 1,000 live births. So that's the way we calculate a under 5 mortality rate, or an infant mortality rate, or a neonatal mortality rate. And the reason I talk about this is not because it relates to the PHR, but because it relates to the demographic and health surveys that I talked about. And at the moment, we're in an era where we actually have data from the DHS. And that hasn't been the case for the last 10 years. But now we have the DHS data from 2016 to 2018. And that can tell us quite a bit about what's happening in a community, in a population. And that's different to telling us what's happening at a hospital level, which is mostly what the PHR tells us. So this is I've just summarized here the data from all the demographic and health surveys that have been done in PNG. And I think this is very useful information. To know this now is very useful because it can give us some confidence that progress is being made. And the reason I say that is because in 1991, the first demographic and health survey showed that the under 5 mortality rate was 133, remember, per 1,000 live births. And so that meant that more than 1 in 10 of all children died in 1991. And now the under 5 mortality rate, based on the 2016-2018 demographic and health survey, is 49 per 1,000 live births. That's still obviously very high, but it is a just over 60%. So 63% reduction in the under 5 mortality rate between 1991 and 2016. And for those who remember what the Millennium Development Goal was, it was for a 2/3 reduction in under 5 mortality rates between 1990 and 2015. So we weren't far off it. And I think that's very encouraging. A lot of people have said that, you know, PNG and other countries in the region didn't do so well in the MDG era. But actually, if you look at the best data we have, you can tell that we got to a almost, not quite, but almost a 2/3 reduction in the under 5 mortality rate. So that's a credit to everybody who worked on this. The infant mortality rate fell from 82 to 33. Part of the reason why we can have confidence in these data, I think, is because the fall was not, it's not just 2 points of data. There's been a progressive decline in the infant and child and neonatal mortality rates in all of that time. And each of these data points are demographic and health surveys, so they were done in the same way. They're not just extrapolations or mathematical modeling, they're actual real data that was collected in the field. And so I think we can have confidence now that the child mortality rate is 49 per 1,000 live births. The infant mortality rate is 33 per 1,000 live births, and the neonatal mortality rate is 20 per 1,000 live births. Now that's, as I say, it's still, we can be encouraged by that. It's still too high. And for example, in the Solomon Islands, if I'm not mistaken, the under 5 mortality rate is around about 16 or 20. So it's still substantially higher than our neighbours, but it does show a lot of progress. And I think that when we look at the PHR data, we can sometimes see where the progress has been made. Anyway, enough of the DHS. I'm going to be talking mostly now about the Paediatric Hospital Reporting Program. And so this is simply a graph of the admissions that have been recorded in the PHR each year. And over the 11 years of the PHR, we've recorded about 200,000 admissions, and they've gone up each year. That doesn't mean that there's been an increase. There's been that same increase in admissions each year, because each year more hospitals have participated in this program. So there's been more data presented. But I do think it tells us some things, and that is there's been a general increase in the number of admissions reported in the PHR, but some of the diseases haven't increased so much. They're still very high, so still large numbers, pneumonia, for example, but they haven't increased at the same rate as what the overall number of admissions have. So you've got here pneumonia and malaria in, what's malaria? In a sort of green color here, meningitis in the pink, and mostly those admissions have been static and stable. And I think what it tells us is that there's been other admissions that have been mostly responsible for the increase in the number of cases. It's not exclusively, because pneumonia admissions have remained very high, as have malaria and TB, but I'll just explain as we go how perhaps they've been replaced by some other types of admissions that have been quite common anyway. This is one of the most important graphs I'm going to show, and this is data from 2020, and I'll just try to explain it. This shows the trend in the under five, the trend in the overall mortality rate in hospitals from 2011 to 2020. And remember, this is 200,000 admissions and around about 10,000 deaths. Okay, but there's been a substantial trend downwards in the overall death rate in hospitals, paediatric death rate. And so for last year, we had 32,755 paediatric admissions and 1,927 deaths. And so the mortality rate was 5.88. And that really is a significant improvement on what it was 5 and 10 years ago. Now, the one thing I want to explain about these graphs is that it's a simple thing, and that is that normally when we talk about the case fatality rate or the mortality rate, it's a raw data. So 1,927 divided by 32,000. Because different numbers of hospitals have reported each year, the way I've drawn the graphs is not just the raw figure, but it's called a weighted average. And you don't need to worry about this too much, but sometimes this figure 5.88 won't exactly be represented by the dot point here. And that's because it's called a weighted average, and it takes into account the differences in hospitals that have reported each year, and it gives a weighting for the number of cases and deaths that they report. It's a more accurate way of looking at trends over time. So these graphs that I'm going to show you are called weighted averages. Don't worry about that too much. The main thing is to know how to calculate a case fatality rate, which is simply the deaths divided by the admissions times 100, right? And that comes out to 5.88. So that's currently our mortality rate, pediatric mortality rate in hospitals. And it's a lot lower than what it was 5 and 10 years ago. Now, this is a complicated graph, but it breaks down. What I've tried to do in this graph in this table is to break down the admissions and deaths for 2020 and the case fatality rate. And then I've compared that to the average case fatality rate between 2009, when we really started collecting substantial data, and 2019. So the previous 10 years or 11 years compared with last year. And I've color coded each of the diseases, and you can tell from the color coding which diseases we seem to be improving on, and which ones are not really changing much. So these ones that are sort of orange are not changing much. If anything, they're static or going up a bit. Probably not going up much, but there's been no improvement. And the ones that are green, thanks. The ones that are green, there's been a substantial improvement in case fatality rates. The ones that are blue or grey down here, the numbers are too small in 2020 to really make any judgment as to whether it's up or down. You couldn't make any judgment based on these small numbers. So I really want you to look at the ones that are green and the ones that are orange, or whatever color that is, orange, I think. And so you can see that for pneumonia, we had 6,217 admissions, and there has been from last year, compared with the average on the previous 2 years, there has been a substantial fall in case fatality rate. Similarly for severe pneumonia, which is a subset, I'll explain this in a minute, but it's a subset of pneumonia cases. For neonatal conditions, there's also been a drop in case fatality rates. For diarrhea, there's probably been a reduction in case fatality rates. For severe malnutrition, there's definitely been a reduction. Tuberculosis, there has been a bit of a reduction. Large numbers, I'll explain that in a while. But there are a number of conditions for which there really hasn't, we couldn't convince ourselves there's been any improvement, such as meningitis and HIV and anemia, rheumatic heart disease and congenital heart disease. There's really been no improvement in the overall outcomes for those conditions. And I think there's a reason, that there are reasons why that is, and I'll try to explain them as we go along. So for pneumonia, this has been one of the most encouraging, I think, improvements that we've seen in the last 10 or 15 years. And that is that now is a very substantial improvement in the death rate from pneumonia. Still, pneumonia is the most important cause, or the most common cause, of admission to hospitals. It still makes up nearly 19% of all admissions. So the largest number of admissions, you all know that. But we are down to a case fatality rate of 3.1%, which is very different, very lower, much lower than what it was before. As I said, severe pneumonia is a subset of pneumonia. And the reason why it's useful to look at this subset is because it's standardized for severity of illness. We all know what severe pneumonia is. That is, children who've got severe chest indrawing or inability to feed because of respiratory distress, or hypoxemia, or cyanosis, or some other emergency sign. And this is a very standardized severity classification based on the World Health Organization's classification. And so we can be fairly confident, I think, because all health workers know what severe pneumonia looks like, we can be fairly confident that they're calling the same disease severe pneumonia last year and 5 years ago as what they're calling it now. And I think it's encouraging, because there was a time in, not that long ago, 5 and 10 years ago, when our severe pneumonia case fatality rate was well above 10% in most hospitals, and above 15%. The average was above 15%. Can you imagine that? 15 and sometimes 20% of children with severe pneumonia died. And now we're down to 7.7%. And that is I think it's worth reflecting on why those improvements have occurred. And they have, I think we've thought a lot about this, of course, and they have occurred because of better clinical care. There's been a more systematic approach to the care of children with pneumonia, and particularly the use of pulse oximetry to detect hypoxemia, and the more widespread use of oxygen concentrators to ensure that all children with hypoxia got oxygen. I think there's been improvements have paralleled the introduction of vaccines. So you all know that the HIV vaccine, the Haemophilus influenzae type B vaccine, was introduced in 2007-8, and then the pentavalent vaccine, as pentavalent, and then the pneumococcal conjugate vaccine, the PCV13, was introduced in 2013 and 14. And I think they've made a big difference to not so much the numbers of children with pneumonia, but the severity of illness of children with pneumonia, and the case fatality rate. And what all of this has done, I think, is change the epidemiology of pneumonia from predominantly bacterial pneumonia to more viral pneumonia and viral bronchiolitis. And that's the same change in epidemiology that's being seen in most countries, a sort of shift from severe bacterial pneumonia to a bit more viral pneumonia. Now, of course, we all know that in PNG and Solomon Islands, it's not that simple, because many children with bacterial pneumonia also have viruses, and most children with bacterial pneumonia have viruses, and some children with viral bronchiolitis have a secondary sort of bacterial bronchitis. And so often it's rather different in some countries, where you can look at a child with viral bronchiolitis and say, well, they've just got a virus. I think in PNG and in Solomon Islands, we can't always do that. And many children will have a drip aspiration of bacterial pneumonia. So that's why they do tend to improve with antibiotics. So, but that does, I think it does explain this change in epidemiology and the better clinical care the use of oxygen more liberally and pulse oximetry for monitoring really does explain, I think, why we are seeing a lower case fatality rate. And I think the health workers have just got better at managing pneumonia, I think. So I won't labour this too much. You can go and look at the recommendations in the annual report, but these are really the recommendations that the group that put together the annual report thought were really relevant to ongoing improvements in pneumonia. And that is that there must be a system of triage and rapid treatment of the sickest patients in our emergency departments and outpatients departments. And that part of the children's ward, for most of the hospitals it is like this, but we really need to make sure that every hospital has part of the children's ward is properly equipped to provide the things that, not intensive care with mechanical ventilators, but oxygen, and can give safe intravenous fluids and have proper monitoring, close monitoring 24 hours a day. So all of those things like a high dependency level care in a children's ward need to be in place, and that has to be set up in every ward. That there has to be adequate oxygen supplies and staff trained in how to give oxygen, and there has to be adequate stocks of antibiotics to treat pneumonia. Not always has that been the case. There needs to be regular clinical monitoring, including with pulse oximetry. We've seen that to be really effective in recent years, and we need to train more staff in the care of seriously ill children. The Hospital Care for Children training course has been really successful, I think, in many provinces now, and we need to make sure that all health workers have a chance to have gone through that course. And we need to pay attention to, having the right number of nursing and medical staff and the supervision of those nursing and medical staff all the time. And these are really crucial to, if we want to go below 3.1% for all cases of pneumonia and 7.7% for severe pneumonia, we'll only do that by, putting in place these measures, I think. This is the sort of monitoring chart we've talked about, haven't we, before? In these talks, we've talked about this, and some of the hospitals are now trialling these types of monitoring charts where there is a colour coding of the vital signs, so that when a child falls into the red zone, then we know that something should be done, that you should escalate the care to a more senior doctor to see the patient. I think we need to get these types of colour-coded monitoring charts in all the hospitals, so that we know if a child's getting into the amber zone, they're starting to get a bit worse, and if they get into the red zone, then they're even worse. This type of monitoring chart has been used in almost all countries now, and they've been, as I say, very successful in going that one step further in terms of improving quality of care. I'll try to go a bit faster in the talk so that we don't labour everything, but just another area that's improved a lot in the last 10 years is the management of severe malnutrition. So last year, 2,377 children were admitted to the 24 hospitals with severe malnutrition. Remember, that's a weight for age, less than 3 standard deviations below the mean, or severe wasting, or kwashiorkor, nutritional edema. And that made up 7.3% of all admissions. And that's a lot less than in previous years. It used to be that it was more than 10% of all admissions had severe malnutrition, and in this last year it's down to 7%. And we've got the mortality rate of severe malnutrition down substantially. It's down to 10%. Now you'll see that it looks like it's higher than 10% here, up to 15%, but again, that's a weighted average. It's a weighted average. The actual mortality rate in the raw figures for 2020 are actually 10%. And I just can't quite see it at the moment, but I think it's 10%. You can see that in the... Someone else. I wanted to... If you've got your device on, could you please mute it? Thanks. I wanted to show this data because it shows you the number of admissions that have occurred each year with severe malnutrition. There has been, in the first year, there was fewer hospitals involved. But subsequent to that, there's been actually roughly the same number of children with severe malnutrition, but it's a lower percentage of all admissions. There was a stage there where it was well over 10% of all admissions, and now it's substantially less than 10%. And the case fatality rate has fallen substantially. So there was a time when about 20% in most hospitals of all children with severe malnutrition died, and now we're down to 10%. And as you probably know, the World Health Organization says that we really should be trying to achieve a mortality rate of less than 10% for severe malnutrition. We're almost there. The other statistic I think is important is that the number of hospitals that have a case fatality rate for severe malnutrition that's more than 20%. This is sort of a case fatality rate that we would all say is too high, and we could do better. And this has been falling over the years. So even though more hospitals have contributed to the PHR data, fewer hospitals have case fatality rates above 20%. And most hospitals now have case fatality rates that are around about 10%. So we can be happy, I guess, that there's been an improvement in the outcomes for severe malnutrition, but we can't be complacent about it, just like with pneumonia. I won't go through all this, but the recommendations for how to improve further the management of severe malnutrition are in the annual report, and these are the recommendations made by the Paediatric Society for the further improvements in mortality rates for children with severe malnutrition. In many of these things we've done in the last 10 years through a more systematic approach to the management of severe malnutrition, particularly the use of ready-to-use therapeutic feeds and having, in most places, most hospitals, better formulas to use, F75 and F100. There's been a lot of improvements, I think, systematic improvements in the management of children with severe malnutrition, but we really can do better by doing these things more consistently, and also by doing some things that we haven't been doing. Many of the children with severe malnutrition, I think, are not children with primary nutritional edema, but also have some other underlying chronic illness. And that, in a way, the children with chronic illnesses are the increased proportion of children that we are seeing in our hospitals. And many of these children with chronic illnesses are at risk of malnutrition. So we need to be identifying those children earlier. There's a lot of things we could do. I'll send around these slides, but these are things that are in the report. Meningitis used to be one of the biggest causes of child death, as you know, in hospitals in PNG and Solomon Islands. It really was a big problem. And it's still a big problem, but it's not as big a problem as what it was. And nowadays, so last year, we had 778 admissions from meningitis and 127 deaths. And so that's a case fatality rate of 16%. You'll notice that the case fatality rate for meningitis really hasn't changed that much in all the time we've been monitoring data. And in a way, I don't expect it to change that much. What I expect is that the number of cases will decrease. And that's been the case. The number of cases have decreased, but if a child gets meningitis, then in a way, their mortality rate, unfortunately, will still be around about 10 to 15%, I think. And we should consider that for every child who dies of meningitis, for every one of these deaths, 127 deaths, many more children will survive meningitis with serious brain injury. You see them with a serious brain injury, and that substantially impairs their ability to go to school and participate in their community and eventually get jobs and that sort of thing. So I think that we can improve the clinical care of children with meningitis. There's no doubt in my mind, and we can probably get the case fatality rate down to about, maybe 5 or 10%. But the real solution to meningitis, at least bacterial meningitis, will be improved vaccination coverage. And I think it's already had a big effect, because we don't see we still see children with Hib meningitis and still see children with pneumococcal meningitis, but that's much less common than what we used to see back 10, 15 years ago. So that also has been a big advance, but the overall case fatality rate has not changed that much. So the main recommendations really are that, you know, I know you know this, but it's when we're teaching people about the lessons from the PHR, we need to keep emphasizing that all children should receive the pentavalent vaccine, the Hib, which contains the Hib vaccine, and the PCV vaccines, the pneumococcal conjugate vaccines at 1, 2, and 3 months. We need to really emphasize that, because at the moment our vaccine coverage is too low, and that all children with suspected meningitis, they should have a lumbar puncture where it's safe to do so. And if the CSF's cloudy or has cells on microscopy, then we're treating nowadays with ceftriaxone. We're not using chloramphenicol anymore. And I know you know that that's been a change that happened 10 years, 15 years ago. But as you know, that chloramphenicol is no longer effective for the use of, for the treatment of bacterial meningitis in PNG or anywhere for that matter, because of the resistance from Hib and pneumococcus. There's a lot of recommendations made about the supportive care of children with meningitis in the annual report. I won't go through them, but maybe you can just take some time to read them and check to see whether the way you manage meningitis in your hospitals lines up with these recommendations, because I think we can do better. We can do better about the overall holistic management of children who've got meningitis or febrile encephalopathy. I say febrile encephalopathy because as the number of children with bacterial meningitis falls, we'll still see a lot of children who have other forms of meningitis, such as viral meningitis or other types of febrile illnesses, even cerebral malaria, we still see a bit of. And I think it's important that we have a overall approach to the management of these patients that is a bit more than just, well, we make a diagnosis and we give antibiotics. It's not good enough just to give ceftriaxone and think we're done. There's a lot more supportive care that's required for children who've got meningitis or meningoencephalitis or febrile encephalopathy, that we can probably improve the overall care of those children. I won't go through them all, but we've talked about them a bit before, and you can look at them in the annual report. Now, I wanted to talk a bit about tuberculosis now, and why I think that some things are improving. And it's encouraging perhaps to think that there has been some improvements in childhood tuberculosis, even though I don't think it's as certain, if you like. It's not as certain as what it is with some other diseases, but I think we can be fairly hopeful that there is some improvements. And I go back to the year 2016, 2017, and they were times, so it's only 5 years ago, but they were years when they were, I would say, the peak of paediatric tuberculosis. And our case numbers have fallen since then. Still a lot, you can see, still large case numbers. And I'll just try to explain this graph. The total of the bar is the total numbers of children with TB of any sort. And I've divided it up into those children. The pink is the children that had pulmonary TB, and the blue is children that had extrapulmonary TB. And in the last 2 years, because of the change to using version 12.1 for some hospitals, we've divided it up further because we wanted to incorporate TB meningitis, because I think increasingly the mortality that we see are in children who've got complicated extrapulmonary TB, particularly TB meningitis. And so I've divided it up in this graph. So that's why the orange is only in 2019 and 2020. But in the previous years, the orange, TB meningitis, is incorporated into the extrapulmonary TB, so into the blue. And what you can see is that since 2016, 2017, there has been a reduction in case numbers of children with TB. And that's despite, remember, that's despite the number of admissions going up overall. So the proportion of children that have TB is going down a bit, and that's encouraging. The other bit that's encouraging is the case fatality rate. And this is the case fatality rate from pulmonary TB, or the case fatality rate on the y-axis on the right side. And this is the case fatality rate in blue from extrapulmonary TB. And you can see that there was a reduction in case fatality rate. We perhaps have plateaued a bit in terms of the case fatality rate reduction. This line refers to the y-axis here, and the bars refer to the number of admissions on the left y-axis. So you can see that we have improved in our extrapulmonary TB case fatality rates, and probably there's been some improvement in the pulmonary TB case fatality rates, although it's not exactly certain. Just to underline this, the percentage of overall admissions from TB, again, the number of cases of TB have fallen a bit, still 1,800 cases of TB in 2020 and 32,000 admissions. So we're down to 5.6% of all admissions are tuberculosis, and that's got to be a good thing compared with almost twice as many cases in 2017. So there has been some improvement in that. There's a lot of recommendations about TB that are not just about the management of clinical TB, but also predominantly about the community care of children with TB. And I think there's a number of things that we've learned in the last 5 years about how to manage TB better. And some of these, again, a bit like severe malnutrition, it's been associated, I think, with more capacity, more understanding of the systematic approach to managing TB and where the gaps have been. And one of the big gaps, I think, were in the early discharge of children with TB. And I guess we know now that in most cases, there has to be a very good reason why it's safe to discharge a child with TB before 2 months of therapy. There has to be a good reason. So the default really should be to keep patients in hospital for all of their intensive phase of treatment, unless there's a very good reason not to, unless we can really identify, unless they've got a relatively less serious type of TB, like lymph node TB, and they've got a family that can provide good adherence. I mean, I think there's lots of reasons why we're probably doing this better now than what we were. I won't go through all the recommendations, but you can read them yourself in the report. I mean, the diagnostics for TB have improved in the last 5 years, as you know, and gene expert testing for TB has become more widespread. And I think that's another reason why case detection is better. Just the overall awareness of pediatric TB has improved, I think, a lot. The recommendations about gene expert use in the annual report are that we know how useful it is, and that is that the gene expert test really helps us diagnose especially multi-drug resistant TB. And although the number of cases of TB have fallen, and probably mortality rates from TB have fallen a bit too, the number of cases of MDR TB have probably increased. But the systematic approach to the management of MDR TB, which is, you know, Dr. Solomon and others have taken a systematic approach, I think is one of the reasons why the overall mortality from TB has fallen. But remember that it's important, I think, to remember that the gene expert test can't be relied upon to exclude TB, because as we know, it's only about 1/3 sensitive. And so that means we can't say a child doesn't have TB just because their expert test is negative. And TB in children continues to be a clinical diagnosis based on the history of contact, the clinical features, the radiology, the sputum or the gastric aspirate for looking for acid-fast bacilli, and then other tests such as the gene expert test. And I think when we're teaching people about TB, we have to really be aware that we can't rely on one test for TB, but we've got to be expert enough to consider all of these different clinical features. I'll just admit someone else. We've got to be able to integrate all of these different clinical features. Anyway, the recommendations from the Paediatric Society this year really emphasize that. And it also outlines which children should have been expert tested done. And you know, I think you know the indications for doing expert testing in all patients. All right. I've gone through this a bit, but I think this is a fundamental recommendation that still sometimes we have trouble adhering to, if you like, and that is that sometimes we are a bit too hasty in discharging children. And we know that, 5 and 10 years ago and before that, many of the children who would have severe TB meningitis or severe miliary TB or multi-system TB they would have come into hospital, or they would have been had their diagnosis made, and they would have only had a lesser degree of pulmonary TB to start with, or lymph node TB, or a milder degree of TB meningitis, and then they get discharged too early and then come back with really severe forms of multi-system TB or severe malnutrition and TB. And I think we've learned really that there has to be a good reason for discharging patients before 2 months. And what that means is that we really need to be making health facilities and hospitals more child-friendly and family-friendly, so that patients can tolerate really a stay in hospital that's 2 months. It's a big, that's a big cost burden for families, and hospitals are not always safe places for families to stay. So we need to be looking at the overall family-friendly nature of health facilities. I won't go through that too much. We've talked about that before. But the other recommendation that I think is really important is that even when we discharge patients after they've completed their intensive phase, we really do need to have proper outreach programs that follow children in their homes. And in looking at the most effective TB programs around the world, all the really effective ones have had proper outreach programs where there's been TB nurses that go into people's homes and supervise their DOTS providers and check on their adherence and their nutrition, and provide social and economic support. And these are really fundamental to improving the overall care of children with TB. And that's been done, I think, in a fragmented and patchy way in some hospitals now. And I think we have to see that as being a standard. Anyway, that's a recommendation. You can read it yourselves. I want to go on now and talk a bit about a few other diseases. We've still got a bit of time. Perhaps about some conditions where we haven't had so much improvement. And the first one is HIV. And of course, in the 24 hospitals for last year, we had 473 children admitted with HIV. And of those, 82 were known to have died. Of course, there may be more HIV deaths that we don't know about, but I think you can see from this data that there's really been no progress in the last 5 years. And I think there's some good reasons for that. And it's understanding those reasons that will help us make further improvements. And I think many of you will know the changes that have been made in the last few years that really help. I think in time to come, in the next few years, will show some improvements, but they really need a comprehensive approach. And the reason why I think we've made no progress is that many children, at least up until a couple of years ago, with HIV are failing their antiretroviral therapy because they were still on at least the standard antiretroviral therapy that we were using in 2000 and 2005, nevirapine, lamivudine, and zidovudine. And just for those, I'm sure most of you know, but for those who don't know, I mean, the majority of countries in the world, and we know the same is in PNG, the majority of HIV virus isolates are now resistant to nevirapine and other non-nucleoside reverse transcriptase inhibitors, those NNRTIs. And so now no longer can that be a substantial base for ART in PNG. It leads to immunological failure. And I think the reality is the majority of children on NVP, 3TC and AZT, the majority of those children have never really had full immune reconstitution. And now there is more effective therapy using lopinavir, ritonavir, and abacavir and lamivudine, and those treatments are now increasingly becoming available. And I just would refer you to the new HIV care and treatment guidelines, again on the Paediatric Society website. This is the Health Department treatment guidelines, and they include children and they include these new therapies. And I think it's only really by getting all of our patients on first-line therapy like that. Dr. Meg Gamini Valley and others are doing that, and that I think that will result in a better nutrition, better immune reconstitution, greater freedom from opportunistic infections and progressive malnutrition and all the other reasons why children die from HIV. So this is the key to making improvements in the next 5 years, I would say. We have 10 years ago, we started early infant diagnosis of HIV with PCR testing. We found that was really hard, wasn't it? It's hard to get results back. And now I think the latest is that some hospitals are starting to use gene expert testing for HIV early infant diagnosis. And this is actually a big advance because it's a rapid turnaround test. You don't have to wait weeks or even months for the test to become available. It's as accurate. It's an accurate test for HIV using gene expert based PCR technology. And now that we've got gene expert machines, then hospitals just need to get the gene expert cartridges that enable HIV testing, and then it can be. I think we can start. This is all related actually, because if we don't do early infant diagnosis, then children stay on so-called prophylaxis with nevirapine and AZT for a prolonged period of time. They all get resistance over a period of time if they're on nevirapine. And so a key to this whole project to improve HIV care is going to be early infant diagnosis. You can read the rest of the recommendations, but I just think these things are fundamentally important. The change in new therapies, the change in the way early infant diagnosis occurs, the better a systematic approach to children who've got HIV. They should be seeing a paediatrician regularly, and the need, I think, for better monitoring. There was a period of time where we did CD4 counts, and then most of those CD4 machines are not available or not being used, and now viral load is being measured more. What's really important is a consistent and regular assessment of their immunological and virological success or failure, and so that children are picked up earlier. I would favour both CD4 counts and viral load being done, but I'm not sure that that's going to be possible. I won't go through the other recommendations, but there are a number of other ones on HIV. I mentioned that the chronic non-communicable diseases that have increased, and I think it's only in the last few years we've started to record these conditions in the PHR a bit more regularly. And you can see that I won't go through this too much, but in 2020 we had over 1,000 children admitted with chronic non-communicable diseases. So we often think of NCDs as being very much an adult type thing, cardiovascular disease and strokes and chronic lung disease, but the same occurs in children. And we've got to start thinking about chronic non-communicable diseases in children, because increasingly these conditions are represented in our hospitals. I won't go through it too much, but these children, for some of them, they have low mortality rates, when some have very high mortality rates. And we could probably, and you might think that these are a rather different group of conditions. They're all different. We shouldn't think about them the same, but actually they all have some common features. And the recommendations from the Paediatric Society this year relate to the common features of all of these things, and that, you know, all of these children, no matter what their chronic disease, they need a long-term treatment plan. They need a good follow-up with a trusted doctor or a paediatric nurse. Many of these children, as you know, are kept home from school. They're not allowed to go to school. I mean, we did a study in the last couple of years about children with thalassemia and found that very few of them are going to school. And Dr. Kaspari Amon did her MEd project on children with epilepsy and found not many of those were going to school. And so we need to think about these children with chronic illnesses a bit differently. They need obviously a regular supply of medicines on time and good adherence. And I think we just should think about chronic illnesses as being a bit, not all the same, but they all have common needs. They all have nutritional needs. And the other need I think they have is for the children themselves to understand their condition. And we perhaps have not been so good at that in helping kids understand their disease, whether they've got HIV or whether they've got asthma or other forms of chronic lung disease or rheumatic heart disease, older kids with RHD, then they can understand their condition themselves as well as their parents. So we've often educated parents and not educated children. And I think we need to, especially the kids with HIV, they can be educated and that can help them manage their condition. Anyway, I won't go through this in too much detail. You can read the recommendations from the Paediatric Society in the report. We record cases of vaccine preventable diseases in the PHR, and as you know, there was a period of time in 2016, 2017 when the cases of acute flaccid paralysis were going up when we had the outbreak of vaccine-derived polio. That has thankfully gone down now. We're still reporting a number of cases of AFP, and that's an okay thing because most of those children probably have Guillain-Barré syndrome, not now wild-type polio. None of them have that, and very few of them hopefully have the vaccine-related polio. It really speaks to the effectiveness of the big mass campaigns that happened in 2017, 2018 and 2019 to improve polio vaccine coverage, and that's why the numbers have now fallen. Last year we had 9 cases of tetanus and 4 deaths, 28 cases of whooping cough, 4 of measles and 2 of rubella. And the sad fact is that vaccine coverage is too low, still too low. And what worries me and many people is that we really haven't got vaccine coverage at the levels that would be needed to prevent the next outbreak of measles. And as you know, we had a big outbreak of measles in 2013-14, and we had an even bigger outbreak of measles before that in 2001, 2000 to 2002. And I worry that we're up for another big outbreak of measles again, because this is from the DHS, it's not from the PHR. We have population-based data that suggests we're only achieving about 59% coverage for even one dose of measles one dose of measles beyond 6 months, so the 9-month dose. And we know that if we don't achieve more than that, then we won't be able to avoid the next outbreak of measles. There was a time in 2006 where we got up to 80% coverage. That was sort of close to the best we ever did. In 2014, it was 85, but that was immediately after the mass campaigns. So was 2006, immediately after the mass campaigns. It seems like we really need to be improving this now. I know with the last round of the polio measles vaccine was given, which is a good thing. So maybe we're up a bit higher, but I worry that with changes in the vaccine administration with the lockdowns and things, that vaccine coverage may be even lower. So we need to pay attention to this. Okay, the recommendations are really standard. This is what we need to teach people to report any of the reportable diseases, acute flaccid paralysis or acute fever and rash or whooping cough, to report them to the provincial disease control officers. I'll just touch on neonatal mortality before we finish. And you know that neonatal cases make up a lot of our paediatric admissions, and we are doing a bit better. This is another area where we are doing a bit better, and the neonatal case fatality rate is falling as the number of admissions of neonates increase. And the number of admissions are increasing partly because the number of hospitals is increasing who are reporting, but also perhaps because the birth rate's not falling, which is not such a good thing. but the mortality rate is 5.3% for neonates. That's it's lower than what we've previously had. Just over half of all admissions for neonates were infections, so neonatal sepsis, pneumonia, meningitis, cord sepsis, skin sepsis, diarrhea. And the case fatality rate for those conditions is around about 6%. There has been probably an improvement, but not a little improvement, I would say, in neonatal sepsis management. One condition, a bit like HIV, that hasn't changed, I think, over the years, is that the case fatality rate for birth asphyxia really hasn't changed. And the numbers of cases of birth asphyxia really hasn't changed. The number of cases is if anything, increased a bit. More than a third of all neonatal deaths are due to perinatal asphyxia. And this is a big issue, I think. We really haven't solved this problem very well. And part of that relates to antenatal care and obstetric care. It's something we can't influence as much, I would say, as much by the management of a baby who is already born. Much of the management has to be preventative in nature. And clearly that relates back to how we manage antenatal care. I won't go through this, but the recommendations are in the report. Every year we track very low birth weight admissions and deaths. And the reason why we've done this, remember, very low birth weight is a baby between 1,000 and 1,500 grams. And this is a really important group of children. And it's really important because it's a very good index of how well we're doing in providing neonatal care. A bit like severe pneumonia, it's standardized for severity of illness, if you like, because we know that all of these babies are very similar, those between 1,000 and 1,500 grams. And you'll see that still about 30% of all babies with very low birth weight died. So the case fatality rate is 30.15%. It's probably a bit better than what it was in 2017, 2018. There's probably been an improvement, I would say, but still it's quite high. I think there's been a bit of an improvement in case fatality rates. And part of that is, I think, has been a bit more systematic approach to the management of very low birth weight babies. But we should think about very low birth weight mortality as being probably the most sensitive index of the quality of newborn care or neonatal care, the sick newborn care that we provide. I won't go through this in too much detail today, but there is now new evidence on the benefits of skin-to-skin care between a mother and a baby. I mean, I sent around the New England Journal of Medicine paper, which came out 2 weeks ago, and I think we'll talk about this another time, but there is really good evidence that in very low birth weight babies, if we can improve the early essential newborn care, the skin-to-skin care with the mother, then their outcomes will improve. And most of the hospitals in that very large study of multiple countries that did kangaroo mother care much better had lower mortality rates, much lower than 30%. So I think we could still, there is scope for improvement that we can achieve in the next 5 to 10 years. I won't go through the recommendations, but they really are focused around the things I've talked about improving early essential newborn care for all babies, because it has an impact on the common causes, neonatal sepsis and birth asphyxia, and very low birth weight. And that if we do early essential newborn care and kangaroo mother care well, then that will really help our neonatal mortality rates. I won't go through them today. There's a recommendation about delayed cord clamping, because you know about the evidence for that, and that really does improve health in infants as they get older. Certainly it reduces anemia in all babies after 6 and 12 months of life, and it reduces intraventricular hemorrhages in preterm babies. So we know that it has overall benefits. But perhaps the biggest recommendation in a way is, just like in all diseases, we should try to avoid harmful practices, which we can get into a habit of. Sometimes our hospitals have harmful practices, and we need to be identifying them, such as separating babies from their mothers. And I'll just give you one example how this can be done. And in the hospitals in this study of kangaroo mother care, they had all the babies rooming in with the mothers, even in the neonatal ICU. So even if a baby was on oxygen or on CPAP, then they had the mother and the baby stayed together. And you might think that's really hard to do, but these hospitals achieved it. And there were hospitals in Africa and other parts of Asia. And I think we need to rethink how we structure special care nurseries so that mothers and babies can be together. And the earliest example I ever saw of this was actually in Sweden, where the best outcomes for extremely low birth weight babies, even babies less than 1,000 grams, was in a nursery in a neonatal ICU, where even if a baby was on a ventilator or on CPAP, they stayed in skin-to-skin contact with their mother. And so that prompted this push, I suppose, for this more having mothers and babies together. And that neonatal unit in Sweden had the best extremely low birth weight outcomes in all of Europe. So it can be done in both rich and poor, I guess, settings. I won't go through the rest of this, these recommendations about newborn care, neonatal care recommendations, but they're focused around the things that I mentioned. And when we're teaching our health workers about neonatal care, we can go through these recommendations and check to see that we're doing these things as best as we can. I want to take a step back now and say, well, I've talked about the recommendations from each of these different diseases and each of these different like program areas. But in the last few years, we've introduced this idea of a pediatric quality improvement program, not just something that tries to fix up pneumonia or diarrhea or malaria or TB, but really thinks about how we can improve the overall quality of pediatric care. And again, these recommendations are in the annual report and they're on the website. You can look at the website if you like. But I think if we want to go the next step, if we want to be down, have hospital mortality rates less than 5%, which we should be aiming at, then we really need to be thinking about having, all hospitals adopting a pediatric quality improvement program. And this is something that pediatricians and child health nurses, we can all be involved in this as a team. And many countries have done this and it's been very successful. I won't go through the components of these pediatric quality improvement program today, but I hope you can see that from looking at the PHR data from year to year and looking at it over a long period of time, we can see the areas that we're improving in, the areas where we still haven't made much progress, and we can see how specific improvements can improve things, but also how an overall quality improvement program can improve things. So, as I say, I won't go through. I'll stop there. I wanted to give this talk today partly so that to make up these slides so that I'll send them to you, and if you want to teach people about the Paediatric Hospital Reporting lessons from 2020 in your hospitals, then you can use the slides, you can change them if you like, cut out some or add some, whatever you like. And at least you can use those slides to maybe give some talks in your hospitals and demonstrate that your hospital is involved in this program and help your staff learn some lessons. So that's all I'm going to say. I'm going to stop talking now. I've talked for far too long, but I'm happy to take any questions from anyone about what I've talked about today. Thank you.
Okay, not a question, but a comment. For the pediatric HIV management, I think next year we might see an increase in the number of morbidity or mortality because I'm in a remote hospital. I sent my HIV orders, which included the pediatric order, but the people in charge of distributing the medication said that of ARTs at the moment.
Yes.
And not only is it nil stock in PNG at the moment, but at the moment we're trying to change from the previous ART to this dolutegravir-based medication. But the dolutegravir is for adults, and for children, they are on the second line treatment, which is the first line treatment now. So I think maybe people don't know that there's no the people who are distributing the drugs, they don't have a transport company to transport the drugs to outside centers outside of Moresby. So I think maybe next year there might be an increase in the HIV fatality rate. Just a comment. Over.
Thank you for that comment. I think what you say is very relevant, actually. And what I've talked about changing, from the very old regime to the new therapeutic regime, it's easier said than done. But we have to at least make the change. But you're right. It's the widespread uptake of that new therapy. It's the training of health staff in the new therapy. It's the availability of pharmaceutical distribution systems that will enable the new medications to be available and used. It's a big program to roll out the change in ART. It's a very, very big program, and I think you're probably right, Angra, that it's quite likely that, well, things might get worse or they might just stay the same for several years before they get better. But we all have to at least understand what the changes that need to happen, and then make every effort to work towards that. I think it's just, again, a comment that probably 10 years ago, our paediatric HIV program was probably a bit better, and that was because CHI PNG was running it, and it was, they were doing a very good job. And perhaps now it's more complicated because there's more resistance around, that's for sure. But 10, 15 years ago, there wasn't that NNRTI resistance, but now there is. And it will take some time, you're right, Angra, for things to improve, but we all at least have to know what the improvements need to be. But I think your point is very valid. Thank you. Okay, well, look, if there's no other questions, we might stop there. As I say, I didn't give a clinical talk today as much as trying to talk about, child health epidemiology, but these are important for trainees, for paediatric registrars, and people doing their DCH and masters to actually understand. But it's also important that we are able to teach other people about an overall perspective on child health. And I think I hope these data that I've talked about today help that. I'll just give a brief half a minute or so for anyone else to ask questions, but then we might stop.
Hi, Trevor. This is Mohammed from RCH.
Yes, Mohammed, do you have a comment?
Yeah, just a question, Trevor. So when you were talking about the case fatality rates, I noticed that the case fatalities in 2014 or 13, thereabouts, there was a dip in that. Is there any particular reason why there was a dip in the case fatality rates around that time?
No, I'm not sure, Mohammed. I think that generally speaking, there's been a trend down in the last 5 years. I'm not quite sure. We can talk about it later, perhaps. But I think generally speaking, for overall, there's been an improvement in the last 4 or 5 years. And as I said, it's been in certain areas and not in others. But no, I don't see a particular reason. We did have higher vaccine coverage in 2014 after the measles outbreak, but I'm not sure that that's the reason. Yeah, we can talk about it later, perhaps. All right. Well, look, if anyone else has got any questions, if no other questions, then I'll send the slides around. You can have a look at them and use them as you like. I mean, usually I send around the PDF, but this week I'll try to send around the full slide set, and you can, you might find that you can give a talk to your nurses on the PHR from last year, and they might be encouraged by that. So. Okay, well, if there's no other questions, then I wish you all a very good afternoon. I thank you all for coming out on your public holiday, as it is in Australia too. And I wish you all a very good afternoon and a safe and a happy week ahead. Yeah. Bye now.
Thank you.
Thank you.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.
Thank you.
Thanks, Prof.
Thank you.